Management of complex pathologies associated with a monochorionic twin pregnancy. The management of twin-to-twin transfusion syndrome. How useful are grading systems for severity of twin-to-twin transfusion syndrome in establishing prognosis? At diagnosis, twin-to-twin transfusion syndrome should be staged using the Quintero system. In addition, measurement of umbilical artery Doppler velocities, MCA-PSV, and ductus venosus Doppler studies should be performed and documented. The Quintero system of staging twin-to-twin transfusion syndrome has some prognostic value, but the course of the condition is unpredictable and may involve improvement or rapid deterioration within a short time span. Amniotic fluid discordance without fulfilling the 8 cm and or 2 cm criteria, for example, within the normal range, together with normal umbilical artery Doppler velocimetry, is associated with good outcome, 93% overall survival, and low risks of progression to severe twin-to-twin transfusion syndrome of 14%. There is controversy about Quintero staging of twin-to-twin transfusion syndrome since stage 1 disease may not necessarily be associated with the best outcome, and indeed, recipient twins within stage 1 twin-to-twin transfusion syndrome may have evidence of cardiac dysfunction. What is or what are the optimal treatment or treatments of twin-to-twin transfusion syndrome and their outcomes? Twin-to-twin transfusion syndrome should be managed in conjunction with fetal medicine centers with recourse to specialist expertise and treatment in supraregional centers. Twin-to-twin transfusion syndrome presenting before 26 weeks of gestation should be treated by fetoscopic laser ablation rather than amnioreduction or septostomy. There is evidence that fetoscopic laser ablative method should be the Solomon technique. Centers performing fetoscopic laser ablation should perform at least 15 procedures per year, rolling 3-year average. Weekly ultrasound assessment, including examination of the fetal brain, heart and limbs, and serial measurements of UAPI, MCA-PSV, and ductus venosus Doppler velocities should be performed. After 2 weeks post-treatment, the ultrasound interval can be increased to every 2 weeks, noting UAPI, MCA-PSV, and DVP with documentation of adequate fetal growth by calculating estimated fetal weight. In treated twin-to-twin transfusion pregnancies, ultrasound examination of the fetal heart should be performed by the fetal medicine specialist to exclude functional heart anomalies. There are supraregional centers in the UK that will offer fetoscopic laser ablation for twin-to-twin transfusion syndrome. Each case should be managed on an individual basis, but commonly, this treatment is for Quintero stage 2 or more, and many will treat this condition if there is Quintero stage 1 with significant polyhydramnios, 8 cm or more, or cervical shortening less than 25 millimeters. The conclusion of the Cochrane review was that endoscopic laser coagulation of anastomotic vessels should continue to be considered in the treatment of all stages of twin-to-twin transfusion syndrome to improve neurodevelopmental outcomes in the child. When compared with amnioreduction, treatment with laser coagulation does not appear to increase or reduce the risk of overall death, stillbirth, neonatal, and postneonatal in this condition, but it appears to result in more children being alive without neurological abnormality. Amnioreduction can be retained as a treatment option for those situations where the expertise for laser coagulation is not available, pending transfer to a unit where such treatment can be obtained, or when the condition is diagnosed after 26 weeks of pregnancy. However, this may complicate future treatment if associated with inadvertent septostomy. There is evidence that fetoscopic laser ablation is the best treatment of twin-to-twin transfusion syndrome in early onset disease less than 17 weeks and late onset disease after 26 weeks. Anastomosis may be missed at fetoscopic laser ablation, and this is the most common cause of recurrence and morbidity. Recurrent twin-to-twin transfusion syndrome can occur in up to 14% of pregnancies treated with fetoscopic laser ablation and be associated with or without twin anemia polycythemia sequence. Such outcomes are associated with a worsening of neonatal morbidity. There is randomized controlled trial evidence that modification of the primary fetoscopic laser technique by equatorial laser dichorionization or the Solomon technique significantly reduces these complications of recurrent twin-to-twin transfusion syndrome and twin anemia polycythemia sequence. Fetoscopic laser ablation can be performed in monochorionic and dichorionic triamniotic triplet pregnancies, but the placental angioarchitecture is usually more complex and the perinatal outcomes are in general poorer than in the treatment of twins. Some women request termination of pregnancy when severe twin-to-twin transfusion syndrome is diagnosed, and this should be discussed as an option. Another option is to offer selective termination of pregnancy using bipolar diathermy of one of the umbilical cords or using radiofrequency ablation with inevitable sacrifice of that baby. This may be appropriate, for example, if there is evidence of cerebral damage in either twin. Most experts advocate that ultrasound examination with brain imaging, fetal measurement, and Doppler assessment, especially of the MCA-PSV, should be performed every week for the first 2 weeks and then every other week following clinical resolution. Twin anemia polycythemia sequence may complicate post-fetoscopic laser ablation in up to 13% of cases, the most common complication after fetal demise. Therefore, at these ultrasound examinations, MCA-PSV should be performed and the result recorded. When should the delivery of monochorionic twin pregnancies complicated by twin-to-twin transfusion syndrome take place? Delivery of monochorionic twin pregnancies previously complicated by twin-to-twin transfusion syndrome and treated should be between 34+0 and 36+6 weeks of gestation. Even after successful treatment, regular ultrasound surveillance should be routine. Consideration should be given to delivery of the surviving twin or twins between 34+0 and 36+6 weeks or earlier if there are concerns. Prophylactic maternal steroids should be given if possible prior to delivery. Mode of delivery can be individualized, but often this is by cesarean section. The management of selective growth restriction. Selective growth restriction, or SGR, in monochorionic twins requires evaluation in a fetal medicine center with expertise in the management of such pregnancies. In cases of early onset SGR in association with poor fetal growth velocity and abnormal umbilical artery Doppler assessments, selective reduction may be considered an option. In SGR, surveillance of fetal growth should be undertaken at least every 2 weeks with fetal Doppler assessment by umbilical artery and middle cerebral artery pulsatility index and peak systolic velocity. If umbilical artery Doppler velocities are abnormal, the Doppler assessments should be undertaken in line with national guidance measuring ductus venosus waveforms. Clinicians should be aware that there is a longer latency period between diagnosis and delivery in monochorionic twins complicated by SGR compared with growth restriction in dichorionic twin pregnancy or singleton pregnancy. Abnormal ductus venosus Doppler waveforms, reverse flow during atrial contraction, or computerized CTG short-term variation should trigger consideration of delivery. In type 1 SGR, planned delivery should be considered by 34 to 36 weeks of gestation if there is satisfactory fetal growth velocity and normal umbilical artery Doppler waveforms. In type 2 and type 3 SGR, delivery should be planned by 32 weeks of gestation unless fetal growth velocity is significantly abnormal or there is worsening of the fetal Doppler assessment. It is important to prospectively inform parents that in selective growth restriction and twin-to-twin transfusion syndrome, even after apparently successful treatment, there can be acute transfusional events which are neither predictable nor preventable, and therefore, despite regular monitoring, there may still be adverse perinatal outcomes. Once there is a suspicion of SGR or the diagnosis has been prospectively made using ultrasound, the pregnancy should be managed in conjunction with a regional fetal medicine center with specialist expertise in managing this condition. There is a need to measure amniotic sac Likert volumes and to assess Doppler velocities within the fetal arterial and venous circulations. Umbilical artery Doppler evaluation in monochorionic twins with selective growth restriction allows the prospective definition of 3 subtypes, and the consequences are dependent upon this evaluation and gestational age. Prior to viability, 24 weeks, if the small twin has a significantly reduced fetal growth velocity, change in measured abdominal circumference of less than 1 st over 14 days, in the presence of umbilical artery Doppler abnormalities, there is a significant risk of single fetal demise. In such circumstances, to protect the appropriately grown co-twin, selective termination of pregnancy using vaso-occlusive techniques such as bipolar cord occlusion or radiofrequency ablation may be considered. This should be assessed and performed in a tertiary center with expertise. Again, informed but sensitive discussion with patients is mandatory. There is limited evidence to guide clinical care in these complex cases. However, there is international consensus that such monochorionic twin pregnancies require regular review with interval ultrasound biometry to monitor fetal growth velocity and placental and fetal circulation assessment by umbilical artery, middle cerebral artery, and ductus venosus Doppler waveform measurements. The aim is to prolong pregnancy to at least viability and to achieve appropriate gestation for delivery, 32 to 34 weeks, but to avoid the complication of single fetal death and the consequences for the surviving fetus. Timing of delivery, less than 32 weeks of gestation, is dependent upon assessment by computerized CTG and/or ductus venosus waveform velocimetry. For monochorionic twin SGR, where there is umbilical Doppler abnormality, delivery should be undertaken at 32 weeks, in line with singleton FGR with AREDV. The placental anastomosis in monochorionic twins paradoxically may be beneficial for the smaller twin, as transfusion from the larger twin may compensate for the placental insufficiency, thus interfering with the natural history in comparison with singleton and dichorionic twin pregnancies. This is also associated with the presence of artery-to-artery anastomosis. This prolongs survival in the growth-restricted fetus, resulting in a longer latency period to deterioration and delivery, up to 10 weeks versus 3 to 4 weeks from diagnosis of FGR. In monochorionic twins, where the placental vascular anastomosis remain intact, There is a risk of acute intertwin transfusional events causing fetal death and morbidity in the form of neurological morbidity. This is true of apparently uncomplicated monochorionic twins, but more prevalent in monochorionic twins complicated by selective growth restriction and even treated twin-to-twin transfusion syndrome. Management of twin anemia polycythemia sequence or TAPS. Clinicians should be aware that the natural history, fetal and neonatal implications, and optimal treatment and/or surveillance of monochorionic pregnancies diagnosed with twin anemia polycythemia sequence are poorly established. Fetoscopic laser ablation for the treatment of twin-to-twin transfusion syndrome using the Solomon technique significantly reduces the risk of recurrent disease and twin anemia polycythemia sequence. The optimal management of TAPS once it occurs is not clear from the literature, but possible options include expectant management, delivery, intrauterine blood transfusion, intravenous and/or intraperitoneal, with or without partial exchange transfusion, selective feticide, or fetoscopic laser surgery. Fetoscopic laser surgery is the only treatment for the cause of this disease, in analogy with twin-to-twin transfusion syndrome, but is technically challenging due to the absence of polyhydramnios and the presence of only minuscule anastomosis. If detected prenatally, management options need to be individualized and uncertainty discussed with the parents. Perinatal outcome in twin anemia polycythemia sequence appears to vary according to the severity. Outcome may range from double intrauterine fetal demise to the birth of two healthy neonates with a significant intertwin hemoglobin discordance. Neonatal morbidity in TAPS appears to be mainly limited to hematological problems at birth. Donor twins may be severely anemic and require blood transfusions, whereas recipient twins may be severely polycythemic and require partial exchange transfusion. The management of monochorionic twin pregnancies complicated by single twin demise. What are the consequences for the surviving twin after fetal death of the co-twin in a monochorionic pregnancy, and what is optimal clinical management? Clinicians should be aware that monochorionic pregnancies not complicated by twin-to-twin transfusion syndrome, selective growth restriction, or twin anemia polycythemia sequence are still at risk of fetal death and neurological abnormality. After a single fetal death in a monochorionic pregnancy, clinicians should be aware that the risk to the surviving twin of death or neurological abnormality are of the order of 15% and 26% respectively. Single fetal death in a monochorionic pregnancy should be referred and assessed in a fetal medicine center with multidisciplinary expertise to manage these cases. Fetal magnetic resonance imaging or MRI of the brain may be performed 4 weeks after co-twin demise to detect neurological morbidity if this information would be of value in planning management. In monochorionic twins, where the placental vascular anastomosis remain intact, there is a risk of acute intertwin transfusional events causing fetal death and morbidity in the form of neurological morbidity. This is true of apparently uncomplicated monochorionic twins, but more prevalent in monochorionic twins complicated by selective growth restriction and even treated twin-to-twin transfusion syndrome. Damage to the surviving monochorionic twin after the death of its co-twin is believed to be caused by acute hemodynamic changes around the time of death, with the survivor losing part of its circulating volume into the circulation of the dying twin. This may cause transient or persistent hypotension and low perfusion, leading to the risk of ischemic organ damage, notably but not exclusively to the watershed areas of the brain. Clinical management is complex and should be overseen by fetal medicine experts with the knowledge and experience to advise parents about the advantages and disadvantages of different approaches. Rapid delivery is usually unwise unless a term as fetal brain injury of the surviving twin occurs at the time of demise of the co-twin. Therefore, immediate delivery only adds prematurity to the possible hypotensive cerebral injury the surviving twin may have already sustained. Serious compromise of the surviving fetus may be anticipated, and this should be discussed with parents, including the significant risk of long-term morbidity. Evidence of fetal compromise, such as significant cardiotocographic abnormality and/or evidence of anemia in the survivor if a single fetal death occurs late in pregnancy, could represent continuing and/or established damage to the brain. A conservative management policy is often appropriate with serial fetal brain ultrasound imaging and a fetal cranial MRI scan planned, commonly 4 weeks after the sentinel event. The appearances of intracranial neurological morbidity on ultrasound are variable and may take up to 4 weeks to develop. Fetal MRI provides earlier and more detailed information about brain lesions, hemorrhagic or ischemic, in the surviving fetus than ultrasound, and its use should be considered. In cases of single intrauterine demise with MRI or ultrasound findings of neurological morbidity, late termination of pregnancy would be an option. The gestational age at the time of diagnosis is relevant, and the views of the parents will be of paramount importance. How should fetal anemia be monitored after single twin intrauterine death? Fetal anemia may be assessed by measurement of the fetal MCA-PSV using Doppler ultrasonography. In monochorionic pregnancies complicated by single fetal death, there was a strong correlation between fetal anemia, assessed by chordocentesis, and fetal MCA-PSV. The presence of an increased MCA-PSV in the surviving twin would suggest fetal anemia and, therefore, a significant intertwin transfusion. This would increase the risk of hypotensive neurological injury and thus would be helpful information in the counseling of parents and timing of fetal brain MRI. Treatment by intrauterine transfusion is controversial as this may improve fetal survival without reducing the long-term risk of neurological morbidity. Timing and mode of delivery in uncomplicated monochorionic pregnancies. What is the optimal timing and method of delivery for otherwise uncomplicated monochorionic pregnancies without twin-to-twin transfusion syndrome, selective growth restriction, or twin anemia polycythemia sequence? Women with monochorionic twins should have timing of birth discussed and be offered elective delivery from 36 plus 0 weeks with the administration of antenatal steroids unless there is an indication to deliver earlier. It is appropriate to aim for vaginal birth of MCDA twins unless there are other specific clinical indications for cesarean section. For uncomplicated monochorionic pregnancies, there may be a higher risk of unexplained fetal demise despite intensive fetal surveillance. The majority, 58% of women with uncomplicated twin pregnancies, give birth spontaneously before 37 plus 0 weeks. As with all pregnancies, parental views will also be important in reaching a conclusion about the best individualized method of monochorionic twin delivery, including opting for cesarean section. In addition to the complexities of twin delivery, for example, malpresentation, there is a small risk of acute feto-fetal transfusional events during labor And this is one of the reasons why continuous electronic fetal monitoring during labor is recommended. Monochorionic, monoamniotic, or MCMA pregnancies. What are the specific problems of MCMA pregnancies and how should they be managed? Monochorionic, monoamniotic twins almost always have umbilical cord entanglement when visualized using color flow Doppler. Such a finding has not consistently been demonstrated to contribute to overall morbidity and mortality. MCMA twins have a high risk of fetal death and should be delivered by cesarean section between 32 plus 0 and 34 plus 0 weeks. Higher order multiple pregnancies with reference to monochorionicity. What is the outcome of monochorionic and dichorionic compared with trichorionic triplet pregnancies? Clinicians should be aware that monochorionic, dichorionic triplet pregnancies have higher fetal loss rates than trichorionic triplet pregnancies and may be complicated by feto-fetal transfusion syndrome, selective growth restriction, and twin anemia polycythemia sequence. Selective reduction should be discussed in all higher-order pregnancies, including triplets. Increased ultrasound surveillance is warranted in a fetal medicine center with expertise to manage such cases. Discordant abnormalities in monochorionic pregnancies. What is the incidence of and the therapeutic options for discordant abnormalities in monochorionic pregnancies, including twin reverse arterial perfusion sequence? Monochorionic twins that are discordant for fetal anomaly must be referred promptly for assessment and counseling in a fetal medicine center with consideration for treatment. Karyotyping of monochorionic twins should be managed in a fetal medicine center. Meticulous mapping of the position of the twins within the uterus should be performed both at the time of prenatal diagnostic tests and invasive treatments. During amniocentesis, both amniotic sacs should be sampled in monochorionic twin pregnancies unless monochorionicity is confirmed before 14 weeks and the fetuses appear concordant for growth and anatomy. Prior to invasive testing or in the context of twins discordant for an abnormality, selective reduction should be discussed and made available to those requesting the procedure after appropriate counseling. Monitoring for disseminated intravascular coagulopathy is not indicated in monochorionic twin pregnancies undergoing selective reduction. Selective feticide by intravascular injection of an abortifacient is not an option in monochorionic pregnancies because of the presence of placental anastomosis. The potential risks of intrafetal and/or umbilical cord ablative procedures should be discussed prospectively, including the risk of co-twin loss and urological morbidity. Documentation and discussion of heterokaryotypic monozygotic karyotypic abnormalities should take place. A higher rate of structural anomalies is observed in twins compared with singletons. Approximately 1 to 2% of twin pregnancies face the dilemma of expectant management versus selective termination following diagnosis of an anomaly affecting only one fetus. Structural anomalies in monochorionic pregnancies are twice that expected in dichorionic pairs given the monozygosity. Detailed ultrasound assessment, fetal karyotyping, and a discussion of prognosis is required with reference both to the abnormal and normal twin. Selective termination in a monochorionic pregnancy is an option, but as the fetal circulations are not independent, it cannot be performed with injection of medical therapeutics because of the effect on the co-twin. More invasive and higher risk procedures such as cord coagulation and intrafetal ablative procedures, such as radiofrequency ablation, are necessary to induce termination of one twin without causing morbidity or death in its co-twin. It is essential that at the time of prenatal diagnostic tests, the pregnancy is mapped carefully, noting the position and site of the fetuses in relation to the placenta and amniotic sac, and documented. This is ideally performed by the operator who would perform the technique of selective termination of pregnancy if required. It is mandatory to discuss selective termination of pregnancy and complicating factors in monochorionic twins, including the potential risk to the normal twin, preterm rupture of membranes 10 to 15%, and chorioamnionitis remain significant complications. Monochorionic twins complicated with an acardiac twin and twin reverse arterial perfusion sequence do not always require invasive treatment. Selection for treatment appears to be dependent on the relative size of the acardiac twin to the pump twin. The larger the acardiac twin, the greater the risk and the need for therapy, and the presence of any cardiovascular impairment in the pump twin. If treatment is considered, then there is some evidence that treatment should take place before 16 weeks of gestation, but evidence is not strong, and it should be performed in centers with expertise in such treatment modalities. Careful monitoring and ultrasound surveillance are required. Rarely, monozygous twins can have different chromosome makeups. This is known as heterokaryotypic monozygous twinning. When anomalies are identified in the first or early second trimester in one of a monochorionic twin pair, which may be markers of aneuploidy, a discussion should take place as to the merits and risks of chorionic villus sampling versus waiting for a double amniocentesis at 15 to 16 weeks when both sacs are sampled and the individual karyotype of each twin can be determined with certainty. Conjoined twins. How are conjoined twins diagnosed and what are the outcomes? Conjoined twins are exceedingly rare and prenatal assessment is required in a tertiary fetal medicine center so that diagnosis can be confirmed and prognosis discussed in conjunction with a multidisciplinary team. Conjoined twins are very rare and by definition are monochorionic monoamniotic twin pregnancies. The prevalence is 1 in 90,000 to 100,000 pregnancies. Such MCMA twins are complex and require careful detailed expert ultrasound imaging, usually including MRI, and multidisciplinary discussion. Most cases are now prenatally diagnosed and delivered by elective cesarean section, but vaginal deliveries of conjoined twins are reported. Risk of dystocia and uterine rupture has been reported in association with cases and diagnosed prenatally. Prenatal diagnosis of conjoined twins with ultrasound is now well reported from the first trimester, with detailed assessment of cardiovascular anatomy, important for determining prognosis and planning management. What are the training competencies required for managing monochorionic pregnancies? All sonographers who undertake routine ultrasound scans during pregnancy must be trained to establish chorionicity and the correct labeling of twins. All sonographers who undertake mid-trimester, 18 plus 0 to 20 plus 6 weeks, and fetal growth scans of monochorionic twins should be made aware of the appearances of twin-to-twin transfusion syndrome, selective growth restriction, and twin anemia polycythemia sequence, and the need to refer patients onto specialist centers if such features present. Fetal medicine centers undertaking fetal therapy for relatively rare complications of monochorionic twins should have a minimum of 2 experienced operators and more than 15 cases per year, rolling 3-year average to maximize perinatal outcomes and minimize long-term morbidity.